Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, my name is Kalume Brigido. I'm one of the Musculoskeletal Radiologists at the University of Michigan. The topic today is sonographic approaches in the evaluation of the distal biceps tendon. I have no disclosures. Ultrasound evaluation of the distal biceps tendon can be challenging, and this is related to the deep and oblique course of the tendon as it dives down to insert in the radial tuberosity. This can lead to poor visualization of segments of the distal tendon and problems with anisotropy, which happens when the ultrasound beam is angled relative to the long axis of the tendon, resulting in areas of hypoechogenicity simulating pathology. There are different sonographic approaches that we can use when evaluating the distal biceps tendon, and a combination of these approaches can be helpful in those more difficult and challenging cases. Also, some of these approaches allows to perform dynamic imaging, which is very helpful, particularly when we are trying to distinguish between partial versus complete tendon tears. Evaluation of the distal biceps tendon can be done with the patient sitting, with the elbow resting on the table, or laying supine. We prefer to use a high-frequency linear transducer of at least 10 to 15 MHz. The different sonographic approaches include the anterior, medial, lateral, and posterior, or so-called cobra position. The anterior approach is the most commonly used. We ask the patient to have the arm in extension and the forearm in supination, as we can see here. We start the evaluation placing the transducer in the transverse plane just proximal to the antecubital fossa. At this level, we will see the biceps muscle and tendon, which is the most superficial structure, and deep to it, the brachialis muscle. So here we have a transverse plane where we see the superficial, normal, echogenic biceps tendon, and just deep to it, we see the brachialis muscle. Here we see the echogenic cortex of the humerus. As we move the transducer more distally at the level of the elbow joint, we see the brachial artery, and the biceps is sitting just lateral to it. So the brachial artery can be used as a landmark to identify the tendon. Here we are at the level of the joint where we see the hypoechoic hyaline cartilage, and then we see the brachial artery, and just lateral to it, we can see the biceps tendon. So the brachial artery can be used as a landmark to find the biceps tendon, which is sitting just lateral to it. And again, deep to it, we see the brachialis muscle. The tendon is followed in the transverse plane from proximal to its distal insertion at the radial tuberosity. So here we see on this video clip the tendon coming from a more superficial position, goes deeper, diving down to insert at the radial tuberosity, as we can see here. We then turn the transducer to a longitudinal plane, and the tendon is again followed from proximal to its distal insertion at the radial tuberosity. So here we have the tendon superficial to the brachialis muscle. As we come from proximal to distal, we see the tendon is going deeper to insert at the radial tuberosity. Here on this video clip, we can see the tendon as we scan all the way to its insertion at the radial tuberosity. So a drawback with the anterior approach is anisotropy, which is an issue here, and also we cannot perform dynamic imaging with the anterior approach. When evaluating the distal biceps tendon using the medial approach, we ask the patient to have the elbow flexed at 90 degrees and the forearm held in supination, as we can see on this picture. The transducer is placed parallel to the humeral shaft, directly medial to the biceps tendon. So the transducer is parallel to the long axis of the tendon. The corresponding sonographic images is what we see here, where you can see the echogenic cortex of the radial tuberosity, the fibrillar appearance of the biceps tendon inserting in the radial tuberosity, And actually, we can see the full insertion of the tendon in the radiotuberosity. And superficial to it, we see the anechoic brachial artery, which is an excellent acoustic window to look at the biceps tendon. As the transducer is placed in the longitudinal plane parallel to the distal biceps tendon, there are less issues with anisotropy using the medial approach. This approach also allows the evaluation of the tendon with dynamic imaging. So we ask the patient to do pronation and supination, and you can see the normal motion of the fibers. This is very important when we are assessing for the presence of a partial versus a complete distal biceps tendon tear. Now moving to the lateral approach, the positioning of the elbow is very similar to the medial approach. We have the elbow flexed at 90 degrees and the forearm in supination. So we place the transducer on the lateral aspect of the elbow in a longitudinal plane parallel to the biceps tendon. And here we have the corresponding sonographic imaging. We see the cortex of the radius, we see the supinator muscle, and here we see the nice fibrillar appearance of the biceps tendon. As with the medial approach, the lateral approach has less issues with anisotropy, and again, this is related to the positioning of the transducer in the longitudinal plane parallel to the biceps fibers. A great advantage with the lateral approach is the ability to perform dynamic imaging. So again, we ask the patient to do pronation and supination, and we assess for tendon motion. This is a very important information to provide when we are looking for biceps tendon tears. A drawback with the lateral approach is that, as you can see, the shadowing from the radius obscured the visualization of the distalmost insertion of the tendon. Also, there is a shadowing at the edge of the supinator muscle, which can create some hypoechogenicity in the tendon at that level. Moving to the last approach, which is the posterior approach, also named cobra approach or cobra position, we ask the patient to have the elbow fully flexed and the forearm in pronation, as we can see here. So we place the transducer in the transverse plane at the proximal dorsal forearm. And here we have the corresponding sonographic imaging, where we see the ulna, we see the radial tuberosity, and here we see the distal biceps tendon fibers inserting in the radial tuberosity. As with the medial and the lateral approach, dynamic evaluation of the distal tendon can also be performed with the posterior approach. So we ask the patient to do pronation and supination, and we look for the tendon fibers moving together with the radial tuberosity. This is an approach that can be used for ultrasound-guided procedures, such as bursa injections or aspirations, with less risk of neurovascular injury given the proximity of the biceps tendon to the neurovascular structures. A drawback with the posterior approach is that only the distal tendon insertion is visualized. We cannot see the most proximal tendon fibers. In conclusion, there are different sonographic approaches that you can use to evaluate the biceps tendon. Being familiar with these approaches can help you, as they can be complementary when evaluating challenging cases. The ability to perform dynamic imaging is also very important when we are distinguishing between partial and complete tears, and this can be accomplished with some of the sonographic approaches, but not with all of them. Here are the references used for this presentation. Thank you.